and now we learn a bit more about the old-fashioned story of muscle pathology.
Yeah, I think that we started with the innovative ways. We went to the current ways of genetics, and we go back to the old ways. And I don't know if you noticed, but I have much less time than the others. So I have to explain my things, because it's old. So I have no conflicts of interest with this talk, except that I like pathology, I like muscle biopsies, and that's my conflict of interest. And I work in a center that does a lot of muscle biopsies still. And I would like to make you think out of the box, because you all think about muscle biopsies as a diagnostic test, and I'm going to talk mostly of the muscle biopsy as a diagnostic test. But it can be much more than that. It can be applied to research. We have seen the beautiful talk about the genetics from Gina, and we can help to confirm the pathogenicity of genetic variants. We help with the functional validation of new variants or new genes. It can help, and especially with the new techniques like spatial transcriptomics, it can help to understand the physiopathology of the diseases in situ, and it is being more and more applied to clinical trials. So think that it's not only the past. But to be able to do all that, you need to have in place all the things that allow you to get the best information from that muscle biopsy. I'm aware that it's an invasive technique, so we need to be careful, and when we do a muscle biopsy, we need to think why we are doing that muscle biopsy. And you definitely, like in other techniques, need to give us all the clinical information that you have, as well as all the results of any special investigations that you already have. The muscle MRI can be very useful, the electromyogram, the levels of CK, because sometimes I still receive requests without a CK level for a biopsy. And when you have the muscle biopsy, you need to, when you have the patient, you need to choose the good muscle to make the biopsy and apply the recommended techniques. Once you have the slides, you need to analyze all the pathological findings together and correlate them with the clinical and with the ancillary tests. Otherwise, you can say it was not a very useful biopsy. This is just an example of what we do in our lab. We have a standardized way of collecting muscle biopsy. We obviously collect tissue that is going to be frozen for morphological studies, and I don't do much inflammatory myopathies, many inflammatory myopathies, so I rely much more on snap frozen tissue than on paraffin, but paraffin can still be useful, especially if you are dealing with inflammatory myopathies. We do a lot of electron microscopy in my center, so we always collect a sample for electron microscopy that is fixed in glutaraldehyde, and we need to think about other tests, other exams that we may do in that fragment. So think that you may have proteomics done, you may need to have cDNA analysis, you may need to do cell culture. So be aware of that and collect a little sample for each one of these techniques instead of having 2 samples and that's all, and then you need to go and do another biopsy to the patient. So, and if we have a muscle biopsy, what are we going to look for? And this is the really hard part for me because I need to summarize a lot of information. What are we going to look for? First of all, we need to know the normal morphology of the muscle. I don't know how many of you know that the muscle has a regularly uniform size of the muscle fibers. In the adult, the fibers have a polygonal shape. In the children, it's different. The nuclei are in the periphery. And we have connective tissue that is very hard to recognize by MRI, but we recognize it, and we are working, for instance, in making this correlation between what we see, connective tissue in the muscle in mice and the MRI of the mice. And you need to recognize that there are some structures in the muscle that are normal structures, like the spindle, the muscle spindle, the nerve, and the vessels. So this is just get this keep this image in your mind, how it should look in a normal muscle. And this is a small amount of the techniques we do. We do a group of tests to all the biopsies that are what we call histoenzymatic reactions. And I'm missing one of them or two here, like the myophosphorylase that we do as a routine for myocardial disease, and also the COX-SDH that we didn't replace COX by COX-SDH, we actually do both. And this is a normal muscle, a normal aspect of the muscle. And you can see on the side also a normal muscle, but in electron microscopy. So that is the basis, and then we do other techniques like immunohistochemistry. And what are we looking for? We usually have a lot of things that we look for, like the nuclei. Where are the nuclei? Are they still in periphery, or are they internalized? And this can internalized or centralized. And this can be, this is a guide, because if you have centralized nuclei, you are probably in the presence of a congenital myopathy. Internalized nuclei is an unspecific reaction of the muscle to lesion. You can see that in different pathologies. But you have images like this one. These are MTM1 myopathy, and you see the nuclei really, really well at the center of the fiber. Or this one, a dynamine 2, where you have not only a fiber type disproportion, but also the nuclei that are very internalized. So this is a very, something that we look as a routine. And I could not, because usually when we talk about congenital myopathies, we think about children. And don't forget that adults, and sometimes it's more difficult to think about a congenital myopathy in an adult, and the biopsy can be the solution here. Adults also have congenital myopathies. And this is a particular form of congenital myopathies, a centronuclear myopathy with mutations in BIN1. And you see the gentleman, he was not so young at the time. And this is a type of change, when we see this, that can allow us to give some information to the genetics, that probably go and check BIN1 if there is a mutation or not. So then we go and we look into the fiber size. These images are completely different from the ones I show you of a normal muscle. So here you have a complete, the fibers are all irregular. They have a huge variability of fiber size. I've just put two very specific patterns. This one, where you see these fascicles are completely atrophic, and you have fibers that have a larger size. And this is quite typical of SMA, for instance. If you go into this one, you see that the fibers at the periphery of the fascicles are atrophic. This is what we call the perifascicular atrophy. And there are other pathologies, but we find this particularly in dermatomyositis. If you go to a muscle dystrophy, and this is similar to all of them, there is a variability in the fiber size with atrophic and hypertrophic fibers. And in some conditions, like VCP myopathy, you may think that you have almost a neurogenic atrophy, because this is a myopathy, but you have some small atrophic fibers, angulated fibers, that can make difficult your diagnostic. So the fiber size and the distribution of the fibers is one of the things that we use, that we'll check for. Professor Goebel was talking about the lipids inside of the muscle fibers. And so we look into the muscle fibers and we check if the fiber is uniform, or if you can find, like in here, small vacuoles or larger vacuoles, or for instance, if there are rimmed vacuoles. And each one of these things has a different significance. Here, I start looking into a biopsy, usually the lipids are one of the last stainings I look at, but I can see already, like I see in this trichrome, that is a microvacuoles inside of the muscle fiber, and then when I get to the lipids, I see this accumulation of a huge accumulation of lipids in all fiber types, and also with a large diameter. This is a glycogen storage disease. This is a Pompe disease in this case, with large vacuoles and accumulation of glycogen. And this takes us into a different world in the myopathies. We get out of the metabolic and we are in the rimmed vacuolar myopathies, and you have from hereditary to acquired, like inclusion body myositis or all the other inclusion body myopathy. So it's important to be aware that these anomalies exist. So still in the, well, besides the vacuoles, we look if there is an accumulation of glycogen. This one is quite easy. This is quite typical. The vacuoles are subsarcolemmal, and you have an accumulation of glycogen, and then you have myophosphorylase. This is the control, and this is the patient. And this, the activity of myophosphorylase is absent. So here we do the diagnostic, like this is a McArdle's disease. Then for Pompe disease, you have the accumulation of glycogen, and as I show you in the picture before, and if you do like acid phosphatase, you see that there is an increase in acid phosphatase. So there is an autophagic activity in this condition. And then you can also have strange forms of glycogen accumulation or PAS positive deposits, not glycogen accumulation. As you can see, this is a PAS staining, and this usually stains glycogen. And this is, here it's rather strange. And when we do PAS diastase, this is not so. You see that all the glycogen went away, is digested, but these inclusions, they stay there. So these are polyglucosans. So this allows us to distinguish between real glycogen accumulation and polyglucosans are associated with different myopathies that I cannot explain due to the time. So I'm going to present you a clinical case because I think it's easier. It's a male, 12 months was the age that he started walking, and he was having frequent falls. And he had fluctuating episodes of fatigability and myalgia, and no myoglobinuria. He had hypertrophic cardiomyopathy. He had a fibrillar atrial fibrillation, and he had a pacemaker implanted. He also had a Wolff-Parkinson-White syndrome. A CK, very high CK, and on observation he had a slight facial weakness, amyotrophic scapular girdle and upper limbs, and also weakness on the quadriceps and psoas. Someone wants to guess what I'm, well, it's fluctuating, sorry? Oh, okay, but you have seen the slides. I'm not, so we go to the muscle biopsy of this patient. Is there anything particular in this muscle biopsy? Well, I can tell you, well, there is a slight variability of fiber type, but we have these vacuoles that you can see here, also here. But the glycogen is almost innocent, and there is a type 1 predominance. But any guess now? Cardiomyopathy, child, weakness. Is not a young child, a very young child. So another chance. We have done staining for an antibody that's against a protein called LAMP2. And you see here the control, and you see that LAMP2 is present, and you see here our case, and it's absent. So from the clinics, you didn't get to the diagnostic, but from here, you get to the diagnostic. It's a Danon disease. So muscle biopsy sometimes is useful. And let's go to the mitochondria. So mitochondria and the abnormalities in the mitochondria are some of the things that we'll look at. And I can tell you that for the mitochondria, from the mitochondrial team, I have enormous amount of biopsies, and not all from muscle patients, also patients with encephalopathies and so on, so it's still very useful. And for mitochondrials, you have different degrees of expression of the mitochondrial dysfunction in the muscle. You can have anything, nothing, just a normal muscle, that happens. You can have the very famous ragged red fibers that you see here, that I call it ragged blue when we see it with SDH, the oxidative staining. So these are accumulations of mitochondria at the periphery of the fiber, and it's not normal. The same, but in a lesser degree, you have here, in French, we call this les coups d'ongle. I don't know the exact translation to English, but you see the accumulation of the aggregates of mitochondria at the periphery of the fiber. You see it in trichrome and SDH. And at the end, you see the abnormal morphology of the mitochondria in electron microscopy with the paracrystalloid inclusions and so on. And then you may have a normal trichrome, slightly granular aspect on SDH that may go completely, may be completely non-specific. So you don't expect to say it's a mitochondrial disease that you have always these beautiful red fibers, because it's not the case. And so this is a mitochondrial myopathy. This is a deficiency in COX, and you can see here you have the red fibers, not very well seen with the trichrome. They have an accumulation of lipids, so it gets both of two worlds, like a metabolic myopathy, a lipidosis, and a mitochondrial, so beta oxidation. Some accumulations in the SDH, but what gives you the diagnostic is the COX, where you have one COX positive and all the others are either COX negative or COX pale. And in COX SDH, you only see the SDH mostly. So this is a partial deficiency in COX complex 4. So I like clinics, and I like to see what I have with the clinic and then in the biopsy. So I've put the title Rare Mitochondrial Myopathy or Limb-Girdle Muscular Dystrophy. So this is a consanguineous family. You cannot see very well, but it's a consanguineous family. All of them are affected, but this is the index case. This is a patient from one of my colleagues at the PT Salpêtrière, Guillaume Basset. And he was very astonished when I gave him the diagnostic of this patient. 48 years old female from Morocco, normal development. First symptoms at 34 years old, slowly progressive proximal lower limb weakness, a slight atrophy of the thighs, slight bilateral scapular winging, and the weakness was most of the pelvic girdle more than the shoulder girdle. And the CK was 609, and she had a myopathic electromyogram. So this is, you won't be seeing this many times. I think I've seen this like 3 or 4 times. So the hematoxylinosin, well, the fibers are different, have a different size, nothing. Here, well, nothing special in here. But then you go to the oxidative stainings, and you start to see this, the granular aspect in there. And it's not only one fiber, so they were not all together, but you can see that this exists in other fibers. So it looks like the mitochondria are quite big. We go to the other stainings for the COX, and you see it's even more evident. You have parts of the fiber that are not staining, but then you have like little aggregates of COX material, and this one I think it's particularly beautiful. You see the same here in the COX SDH, and this is an electron microscopy for that patient because Guillaume didn't believe my diagnostic, so I had to prove him. This is a mitochondria, and this is a huge mitochondria. So this is called megaconial myopathy. It's associated with mutations with a gene that is called CHKB, and this patient had a homozygous mutation in this gene. So this is obviously not a very common, as I said, I saw like 4. It's just to show you that sometimes you need to go deeper and look really all the stainings to be able to make a diagnostic. So the other thing we look at is the myofibrillar structure, and for that we use two oxidative stainings, DPNH and SDH. I'm not going to talk much about the structural myopathies because Regan has already talked about the core, central core, multi-mini core, but because I'm more on the adult side. One of the groups of myopathies where we can find anomalies of the intermediate fibrillar structure are the myofibrillar myopathies. And it's not, well, even the ones that are not used to see muscle biopsies can see that, well, hematoxinusing, there is some stuff inside of the muscle fiber. Also with the trichrome, with the gomery trichrome, this is not normal. This may be normal, but this is abnormal. So there are some material inside of the fiber. This corresponds to aggregates, to protein aggregates. And because these proteins do not stain with the ATPases, you see that with the ATPases, there are parts of the fiber that are not stained, and you have a lot of disorganization with rubbed areas in the oxidative stainings. But I think I'm going to be hearing from Professor Goebel because he did most of the work on this kind of myopathies. So in these myopathies, we need to go into the immunohistochemistry. And as you can see here, we stain this for desmin and myotulin, which are proteins that you often see in these myofibrillar myopathies. Actually, desmin is the hallmark. It doesn't mean that all the myofibrillar myopathies are associated with mutations of desmin, but desmin is almost always present when we have a myofibrillar myopathy. So those aggregates are stained with several antibodies. And we also did electron microscopy. We have the disorganization of the sarcomeric structure and the aggregates of desmin also in between other proteins. So the other aspect is the fiber type distribution. So we still do ATPases, although we are doing for also the immunostaining for the different fiber types, but the basis is the ATPases, and this is a normal distribution with the type 2 fibers that stain dark and the type 1 lighter in ATP 9.4, and then is the reverse. Here we have the fiber 2A and 2B fibers and the type 1 fibers that are darker, and this is for us good to look into regenerating fibers like 2C fibers. And this is important. Why? Because when we look this biopsy, I can assure you that in the other stainings it was almost normal, except for a slight slight variation in fiber size. And here, when we stain with the ATPases, we don't see any differentiation. So this is a uniformity of the fiber type, and this very much puts us in the sense of a congenital myopathy. Here, it's different. We have an ATP 9.4, and we see that there is a predominance of the white fibers that are the type 1 and very small atrophic type 2 fibers. And then we also look into how the atrophic fibers are collected. If they are, for instance, in large groups like in here, if there is a type grouping that points towards a neurogenic process with reinnervation. So these are aspects of things that we look into the biopsy that can help us to help in the diagnostic. And then we look into the inclusions, which are really, I think it's beautiful when we look at it in the microscope. So you have seen from Regan the rods or nemaline bodies. This is the aspect in electron microscopy. You have also the cytoplasmic bodies, and if you have cytoplasmic bodies in one biopsy, as a predominant aspect, you can think, for instance, in an HMERF, a titinopathy. This is the aspect on electron microscopy, a core, a dense core, and then some fibrils that go into the periphery. And then another type of things that you can see, for instance, in STEAM1 or even sometimes in congenital myasthenic syndromes is the presence of tubular aggregates that are quite nice in electron microscopy, because you can imagine that are real tubes that are all closer to each other. So this is really a nice image, and they stain quite dark in DPNH, and they are very red on Gomorrah trichrome. So another case, I'm not going to get to the end. It's a 25-year-old male, Ukrainian. He started his symptoms in childhood. He has an actual involvement with a pronounced scoliosis and lumbar hyperlordosis, respiratory insufficiency with chronic hypercapnia, myopathic facies, ptosis, eye arch palate, atrophy of the masseters, autonomous walking with trunk flexion. He was really, really retractile. I saw him when I did the muscle biopsy, but he was still walking. And this is his muscle biopsy. Just as an anecdote, I took 2 fragments, one more superficial and one more profound. And I don't remember which one, but one was almost normal and the other showed this. And if you see here, there are some inclusion, let's say, in the muscle fibers, hyaline, that you can see also with the trichrome, that don't stain with ATPase. And this is, if you have read the book from Muscle Dubovitz, it's there. And it happens in the real life. What is the pathology? Okay, I don't have the time. Those inclusions don't stain with desmin, but they stain with myosin. So this confirms my hypothesis of MYH7 associated myopathy. And actually, this guy had 2 heterozygous variants in this gene. And he had congenital myopathy due to a myosin storage. And I think that if you had went first for genetics, you would be in the retractile myopathies panel, and probably we wouldn't have the diagnostic. Now, progressive muscular dystrophies, you all know the characteristics, the histological characteristics of the dystrophies. Increase in nuclear internalizations, not centralizations, fiber size variation with atrophy, hypertrophy, necrosis, myophagocytosis, inflammation, and regeneration, with an increase in connective tissue and in adipose tissue. So this is the basis for any progressive muscular dystrophy. I'm not talking that here I would do a slightly different for the congenital muscular dystrophies, but I don't have the time. And here, the immunohistochemistry and the immunoblotting are essential to make a diagnostic. You see a Duchenne muscular dystrophy, but this could be a Duchenne or another muscular dystrophy, limb-girdle muscular dystrophy, a sarcoglycanopathy. You see the necrosis. And here, the variability of the fiber size, and then you do the immunohistochemistry, and you see that MANDRA1 and this one that are antibodies that recognize several epitopes of the dystrophin gene are almost absent. The alpha-sarcoglycan, in this case, is pretty much normal. Dystrophin is normal. And I would like to raise awareness for one thing. Even if people think that HLA1 is specific of inflammatory myopathies, it's not. Because you can have, and you see it here, overexpression of HLA1 in muscular dystrophy. So you really need to be very careful when you say this. This is a fun one. It's a guy, 27 years, that was sent to me as inflammatory myopathy. He had lost 12 kilos in 24 months. He was very slim. He couldn't run, jump, or tiptoe walking. He had a modified Gowers maneuver, slight scapular winging, and he had an intolerance to the effort. And previously, he was quite strong. So there were still positive signs in the MRI in different muscles. The CK was a 7,000, and he had a panel for the myositis that was negative because that was the first hypothesis. this is the muscle biopsy. You can say it's probably, it could be a myositis, immune-mediated necrotizing myositis, except that in the middle of all this, I found a rimmed vacuole. So any hypothesis? Would you just do HLA-1 and all MHC class 1 and all the immunostandings for the inflammatory, or would you go into other panel of 27 years old? But that's a good way of thinking. So lots of, and in your way, lots of COX negative STH positive fibers. A rimmed vacuole, COX negative, STH positive. Okay, Congo red in the vessels. So amyloid in the vessels, and you can see those here. So what is this? No, there is deposition of amyloid in other diseases, not just in amyloidosis, like in dysferlin, for instance. And this patient has a dysferlinopathy. Okay, it's confirmed. And I'm staying here because the inflammatory, I don't have the time. It's time to finish. And this is my team. Thank you.
That is wonderful. So, colors, still needed colors for muscle pathology, so therefore this is really excellent. Questions for Teresina? Any interest?
When do you use electron microscopy in your routine diagnostics?
Very small children, babies. And when I have doubts about the kind of intermyofibrillary, if I have doubts if I have like cores or multi-mini cores, because sometimes it's not, I'm not entirely sure, I use as a routine. But we do a lot of electron microscopy because we also like to confirm other aspects, not just for routine, but...
Embed a piece for electron microscopy from each biopsy specimen?
Yes.
So he's like, where's what?
Thank you for this great talk. I want to ask about one case that you mentioned during the course. The patient with 34-year-old woman with megaconial muscular dystrophy, I think. Are there any intellectual intellectual disability in that woman? Because it is very interesting. We see that cases in childhood cases with the mental retardation. So
that was one of the reasons why Guillaume wasn't believing me. That's because this patient is an adult and she didn't have any intellectual deficit. And it's described that in the LGMD forms, you can have a normal intellect, but in children they always have. They usually have
microcephaly and the other things, and it's very interesting. And thank you for the presentation.
Thank you.
So any further questions? I don't see hands, and online currently we don't have.
Okay.
So thanks indeed.